and the sedation, occasional muscle relaxation only when needed. It is using muscle relaxation is not a must. There is a fine balance which exists. There is a fine balance which exists between analgesia, sedation, and occasional paralysis. This picture is very old actually. It was from 1992 from Leicester. This was a patient who needed ECMO for cardiac reasons. She was extubated and she was enjoying everything, reading papers, watching television, communicating with the family, etc. So this is the ideal state we would like to see them, not all of them, but a significant percentage of them while they are on ECMO. So these are the pictures from the other pictures also. Tracheostomized patient over here, able to enjoy his ice cream and have a drink while on ECMO. Pictures from abroad, how they can be managed while they are on ECMO as well, extubation. This is from Krishna, extubatable at one point of time during her care and needed re-intubation later on. She was communicating with family. Family was happy with that as well. So when they get the capability for coughing and remove the secretions, can we extubate by patient when they are getting better? Continue with chest physiotherapy. Mobilization is very important while patients are on ECMO, and fine management of sedation and analgesia will help. When I try to walk in the ICUs, etc., some of them a proportion of them. So that is the ideal state we will be looking for. I know lungs will be like this, but section for an ECMO. As long as they are not pulling the ECMO cannula out, that is okay. So reasonable sedation. What is this is from Krishna Institute of Medical Science. Well, patient was able to and not feeling pain. If they can communicate with us and establish a day-night cycle, if you can, that is the objective we are looking for. So why sedation is necessary? To improve patient comfort, reduce stress, facilitate interventions, allow effective ventilation when needed, encourage sleep and prevent suicide. Inadequate sedation that can rise urine as well. Certain pharmacology can happen during ECLS. This is systemic transition station about pharmacokinetic can be as it result in toxicity of the drug. therapy, they are all important part of non-pharmacological interventions. The sedation wise, there are IV anesthetics like Propofol, Ketamine, thiopentone, etc. The common ones are sedative agents, Benzodiazepines, Midazolam and Lorazepam, they are the common ones. And opioids, morphine is the commonest. If they are needing excessive sedation as a result of absorption onto the circuit, you may have to give supraphysiological doses of morphine. They might need escalation to fentanyl as well, but be mindful that fentanyl is 100 times pharmacologically more potent in equal doses to when compared with the morphine. That is 1 microgram of fentanyl is equivalent to 100 micrograms of morphine. Alpha-2 receptor agonists like clonidine and dexmedetomidine, these are the other ones which can be considered as well. Rarely, inhalational anesthetics like sevoflurane, phenothiazines, haloperidol, and local anesthetic can be considered also. Choice of the sedative drug, for short-term procedures, you might use something like ketamine also, but for long-term procedure, morphine, midazolam, fentanyl, these medications are ideal. As far as possible, try to bring them down by intravenous sedation by instituting oral sedation also in addition to IV sedation, and thereby you can wean on IV sedation. Be mindful of the organ problems with respect to clearance from the renal metabolism, hepatic metabolism, what are its effect on the brain and CVS, etc. Drug withdrawal is also possible afterwards. So Propofol, the important message about Propofol is it is 90% bound to the membrane and circuit. We tend not to use it usually whenever, and probably it can be used as one of stat dose, but we don't tend to use it as a regular medication for a long period of time. When the infusion rate exceeds 5 milligrams per kilo per hour for more than 48 hours with hyperlactatemia, as 90% is found to be adhered to ECLS circuit, we don't tend to use it as a continuous infusion. Ketamine is one of the common medications we tend to use either in a dose of 1 milligram per kilo or 2 milligrams per kilo per dose, mainly for procedural sedation, but it can also be used as a continuous sedation also. It is good for bronchial smooth muscle relaxation if you want that effect. There is not much of effect on the ICP. It is an excellent analgesic also. Morphine is one of the commonly used medications to start with and continuing on. The plasma levels do not correlate with the clinical effect, so you may need higher doses. Low lipid solubility causes slow equilibrium across blood-brain barrier. It is metabolized in the liver. Circuit absorbs up to 40% of morphine. Fentanyl, it is extremely lipophilic. It also has got high affinity for circuit components, but it's potent. It's more potent, so it will have probably a better effect when morphine itself is not helping you. Remifentanil can also be one of the agents which can be used instead of fentanyl, but it is short lasting. So we tend to go for a long lasting medication. This is about the levels, what happens after 240 minutes of 4-hour infusion rate, where they stand up. Some of the unwanted side effects of opioids are vasodilatation, respiratory depression, gut motility depression, etc. Benzodiazepines, the commonest ones are midazolam and lorazepam. But out of these, midazolam infusion is the commonest one. It is also lipid soluble, and to some extent it gets absorbed onto the circuit. Probably you need around 20% increase in the dose requirements. If they are on a high dose of midazolam, you can expect them to be showing effects of withdrawal. Clonidine is one of the alpha-2 receptor blockers, which is very important. medication for blocking the withdrawal effects. Lorazepam, long-acting benzodiazepine, more or less 50% is lost to the circuit. Clonidine, as I mentioned earlier, is one of the useful agents, especially when they are on high doses of benzodiazepines. Dexmedetomidine is another agent which will be useful. We don't tend to use it as a first agent, but later on, if they're needing more medications, then we tend to add on at that stage. Okay. Half-lives. Yeah. You can assess the sedation scores by different sedation scores, Ramsay sedation score or sedation agitation score, modified Glasgow scale, whatever you are used to, that's okay. Bispectral index, it is used more in the theaters, but not in the bedside as such. For the neuromuscular blockers, occasionally when they need paralysis, only for the momentary events, we tend to use paralysis for that. For example, for cannulation, decannulation, or any other surgical procedures being done on them, we make sure there is adequate sedation and analgesia before we use neuromuscular blocking agents. So, as there was one question earlier, you can diagnose under sedation or over sedation by clinical examination of the patient. So that is possible as well. Different scales. Paracetamol is equally important as well for pain control. Majority of the patients tend to be on continuous paracetamol as well as 6-hourly doses. Oral sedation is important to supplement. Daily wake-up is important. Unless the patient is fighting, we tend to stop sedation in a on a daily basis at the time of rounds, and we restart the medication once the patients start moving and they show signs of wakefulness. Then we tend to restart. This applies when they are intubated. When they are extubated, you can mix and match to their requirements. So in summary, assess frequently the amount of sedation needed by a patient and the amount of analgesia needed by the patient. Communicate along common terms, understand the cause of agitation and focus on the treatment. Avoid increasing tolerance and withdrawal symptoms. Daily wake-ups is important to avoid cumulative toxicity between medications prior to extubation. Tolerance may develop at higher doses. This may be our ultimate goal, but I haven't seen we people going to this extent in our country. Someday we will.